So the bottom line is I think we've all hopefully drilled into your brain that the first TAVR choice or first intervention, whether it be surgery or TAVR, is super critical. And I think Joe said very well that before they do their first intervention, they're already thinking about what will we do next time, right? And I think we have to be very academic about our decisions, right? Are we doing these valves because we think we're getting a larger orifice or better hemodynamics or less structural valve deterioration? We really need to balance these concepts with the patient's anatomy and suitability, right? So here's what I mean by being academically consistent. Here's an example of a patient that might come to your discussion table. 77-year-old female, the annulus measures 332. Well, that's solidly in the 20 millimeter range. And someone will say, well, I'm not gonna do a 20, that's too small. I'm gonna do a 23 evolute to do surgery. Okay, no problem, but let's examine that logic. The problem is that a 23 evolute contains a 20 millimeter valve. Okay, the sizing of this is by the inflow, not by the valve. So you're fooling yourself if you think that you're putting in a 23 evolute and getting a larger valve. You're actually getting the same size valve. It's a 20 millimeter valve. Okay, so you're not getting a larger orifice by doing that. So if that's your reason for using this valve, it doesn't make any sense. Okay, and you can measure this yourself, but this is a 23 I've acquired, I've taken my calipers, I've measured it. It's a 20 millimeter valve where the leaflets are. That's what it is. And you can say, well, what about the SMART trial? The hemodynamic data, I'm really compelled by that. Well, the SMART trial was small annuli, mostly females. There are two endpoints. There's a clinical endpoint, which is mortality and disabling stroke and heart failure, which by the way is no different at 2 years. And then there's an echo endpoint. And the echo endpoint is what says, hey, there's a problem here. These gradients are higher, there's more structural valve deterioration based on echo numbers. But if this is true, right, if at 2 years we have 48% of patients, it makes no sense to me. How can a valve that's the same size or actually smaller across the board have better hemodynamics? If your 34 has a 24 valve, how is that better hemodynamics than 29? It doesn't make sense. It's because the echo numbers are reflecting valve design like we were talking about before and not necessarily the actual orifice area. And if 48% of the SAPIEN valves are deteriorated and dysfunctional at 2 years, then how come there's no difference in mortality, stroke, or hospitalizations? How come there's no difference in patient quality of life scores? And how come these patients that had failed valve didn't have to redo surgery or redo TAVR? It doesn't make sense, right? And then this is, I think, the final clincher that really should nail this home, is that if you look at the feasibility of redoing TAVR with these self-expanding evolute, okay, and this is published only just a few years ago, the things that made it most difficult to redo TAVR: female sex was associated with a higher risk of coronary compromise, smaller annulus dimension, lower sinus of Valsalva height, and shorter coronary height. Well, guess what? That's female population. So to say, well, this should be marketed to women, really, it's very ironic, right? Because those are the ones that are going to be the most difficult and challenging to treat and have the highest risk of coronary obstruction later when the valve fails. So I think you need to be really thoughtful about your decision making. And as I mentioned earlier, we know from the literature, there's a huge difference between what you see by Doppler and what you see invasively. Okay? The Doppler gradient does not necessarily reflect the actual hemodynamics of the valve because of valve design and turbulence and other things, which we don't want to get into. But I think the heart team decision now is a lot more complicated. We have to think about TAVR or SAVR and which device. We can't just say surgery and walk away, to Dan's point, because the patient could end up with some major patient prosthesis mismatch or a valve that doesn't play well in the sandbox with TAVR, like MitraFlow or something. And the same thing for TAVR. We can't just say, let's just do TAVR. Whoever brought coffee today, let's put their valve in. You have to be much more thoughtful about it. And I think in the future, with our valve meetings, we're gonna do a lot more virtual simulation before we do the first intervention. And we can see, like in this patient of mine, if I do a 90-10 implant with a 26 evolute, or excuse me, a 26 SAPIEN, I'm gonna be touching the STJ and I'm gonna make my life miserable next time when it fails. So if I simply go to 90-10, I'll be below that, I'll be good. But if I did a 29 core valve or evolute, I'm definitely gonna have obstruction in the future if it fails due to stenosis, but I don't know how it's gonna fail. So this is not gonna work in this patient's anatomy. So I think we need to be thoughtful about that. So I think the bottom line is you want to choose your initial TAVR valve if you're going to do TAVR that has your best clinical outcomes and preserves future options. Don't treat numbers, treat patients. I think that's really important. And I think these virtual valve simulations are going to be very, very useful in the future when we're planning out these things before we do anything. So I'll stop at that point.